Hello everyone, I'm Kang-Sub Kim, Incheon St. Mary Hospital, College of Medicine, the Catholic University of Korea. It is great honor to present our study title, Low Intensity Extracorporeal Shockwave Therapy in Patients with Erectile Dysfunction, by Center, Sham-Controlled, Double-Blind, Randomized Prospective Study. I will show several slides for present the purpose and the result of this study.
Erectile dysfunction is defined as an inability to obtain or maintain a penile erection sufficient for a successful vaginal intercourse. Current non-surgical therapeutic options for a PDE5 inhibitor or intravenous injection with a combination vasoactive agent. However, this therapeutic option is provided symptomatic relief in selected patients. These treatments do not cure the underlying pathology and the results are not always satisfactory. They also carry a risk of adverse effects of complication. ED therapy are limited as spontaneity of sexual encounters as it many require planning and therefore a treatment that aim to reverse underlying cause is strongly desired. Restorative treatment of ED and stem cell treatment and growth factor treatment and gene therapy and tissue engineering. However, these studies are limited to a basic study, so we evaluate the efficacy or safety of low incentive extracorporeal shock wave therapy in patients with erectile dysfunction. This study is a randomized and sham-controlled double-blind prospective study and performed at two referral hospitals. Patients were randomized to receive a placebo treatment or SWT in a 1-to-1 ratio for 6 weeks. It was evaluated at screening 4 and 7 weeks after ESWT treatment. Patients will complete the International Index of Erectile Dysfunction Questionnaire and Erection Hardness Scale and a Sexual Encounter Profile Questionnaire. Furthermore, the development complication was investigated. Increasing criteria manage over 20 years a generally healthy and clinical mild and moderate ED, stable sexual relationship in at least 3 months before treatment, and volunteer participate in information consent sign. Exclusion criteria: history of a hormone and neurologic or physical problem, history of radical prostatectomy or pelvic operation, pelvic radical therapy, or patients with coagulation disorder and using anticoagulants. All patients were scheduled to receive 2 ESW sessions every week for a period of 3 weeks that were repeated after a 3 weeks lasting period. The primary objective was to evaluate the 7 exchange from baseline in the IIEF dominant score, which was assessed to ED at the neurology clinic after termination of ESWT. Secondary outcome is measured was assessed 2 and 7 weeks change from baseline in the EHS and SEP Q2 and Q3 scores. Furthermore, we evaluate the 4 weeks change from a baseline for IIEF dominant score as EP, Q2, and Q3 and EHS. A total 96 participation were considered for enrollment. 1 patient declined participation in this study. 95 subjects who met the inclusion criteria are allocated to groups. A total 38 patients are randomized into ESWT arm and 43 patients were randomized into the sham therapy arm. 6 patients in the sham group and 5 patients in ESWT were dropped or withdrawal of consent during a treatment period. 2 patients in the sham group were one patient withdrew their consent during a 7 weeks follow-up. Therefore, 14 patients were dropped for a withdrawal of consent during this study. The baseline IIEF dominant score ESWT and sham group was 60.6 and 60.7 respectively. There was no statistical difference. IIEF dominant score is increased significantly from a baseline to 7 weeks within a ESWT group compared to that in a sham group. The median change in IIFEF dominant score in ESWT and Sham was 5.1 and minus 2.2 respectively at the 7 weeks follow-up. There was a statistical difference. Significant improvement was seen in the percentage of yes response to a SEP Q2 and Q3 from a baseline ESW group compared to that in the sham group at 7 weeks follow-up. Patient tension over 3-point EHS at 87% in ESWT, 53% in sham group at the 4 weeks follow-up, and then 89% ESWT, 69% in the sham group at 7 weeks follow-up. There is a statistical difference. Complication and side effects such as pain, hematoma, hematuria, and bruising were assessed for an entire study duration. No adverse events were seen during ESWT treatment after a procedure. ESWT significantly improved IIEF score and erection hardness and as well as quality of ability of sexual activity. No treatment-related adverse events were reported during a study. ESWT is safe and effective for mild and moderate ED. Thank you for attention.